Hello everyone, welcome to my medical surgical nursing series. I'm Scott Krueger, and today we're going to be going over peri-op. So with peri-op, we're going to consider the pre-op phase as before the surgery. We're going to talk a little bit about the intra-op phase when the surgery is actually taking place, and then we'll talk about the post-op phase, so after the surgery has been completed, some of the considerations that are important for you to get so that you're successful as a nurse, successful with your NCLEX, successful passing your class. So looking at pre-op, there are some important concepts that we want you to know regarding nutrition, communication, cultural diversity. We also want to try and identify elements in a systems-based environment appropriate in caring for the adult population, and that includes wellness, health, acute and chronic illnesses. It's also very important that we verify pharmacologic therapy for clients based on an understanding of expected pharmacologic actions, safe administration methods, and then data collection for our patients. Those are kind of the general things we want to go over with today's lesson. So, very important, the nurse must prepare the patient for what to expect preoperatively, intraoperatively, and postoperatively. Preparation for a surgery begins before admission. So, depending on what type of surgery it is, we may have weeks, months to prepare for this surgery. So we're going to be teaching in that whole phase. Sometimes a surgery is a bit more urgent. So we have a very limited time where we can discuss things on what to expect with the surgery, teachings, things we want you to do. And in an emergency situation, an emergency surgery, if the patient's unconscious, it may be difficult to go over anything at all. It might be hard to know what their wishes are, because if we find them, they're brought in to the surgery department and we don't know who they are, what they believe in. If it's a life-threatening emergency, we're going to kind of bypass all that because we definitely want to save their life. It's important that we carefully assess the patient before surgery for risk factors or potential complications. Infants and older adults are at much higher risk for complications of surgery due to either having an immature body system or, with the older adult, a decline in their function of their various body systems. As the nurse, we try to prevent or intervene in the many potential complications that are possible with surgery. We said, once again, surgery can be elective. Elective is where, you choose to have it done. We can take, weeks, months to prepare for that. Urgent, and then emergency. Looking at diagnostics that we want to do before a surgery, we may want to do a CBC, CMP. We want to look for any signs of infection, see how thin the patient's blood is. So we do that to determine the origin and cause of the disorder as well, or if it's something like cancer, we want to do a biopsy and try to see what kind of cancer cells we're dealing with, because that will kind of determine the treatment for it. With our curative surgery, we're looking to resolve a health problem by repairing or removing the cause. With restorative surgery, we're looking to improve a patient's functional ability. In palliative surgery, we're looking to perform or relieve symptoms of the disease process. So we're not looking to cure this patient in palliative. We're just trying to ease their suffering and make things a bit more comfortable for them. Of course, cosmetic surgery is definitely an elective surgery, and that's usually to enhance the appearance or alter or enhance our appearance. Looking at some, we definitely want to consider transfusion for procedures along with cultural considerations. So during surgery, there's a big possibility that a patient may lose a lot of blood, so it's important that we determine the patient's blood type. So we do a blood type and cross match before the surgery, just in case a patient needs an immediate blood transfusion. So very important that we give them the right blood, or we can cause some kind of reaction that is not going to be very good for any of the parties involved. Very important that we take a patient's cultural beliefs and values regarding surgery into consideration before we do it. There's some cultures that they don't want any body parts removed from them. It's in their culture that you're not supposed to take anything out of the body. Some cultures want to hold on to anything that you've taken off. And then especially with Jehovah's Witnesses, it's important that we realize that with Jehovah's Witnesses, they do not accept blood from other donors. And, it's important that we, in this case, where they don't receive blood from other donors, we can do certain transfusions such as what we call autologous, and that is prior to the surgery, the patient banks their own blood. They build up their own blood supply. In case they do lose a lot of blood, they can receive a transfusion of their own blood, and we call that autologous. There are certain bloodless procedures that are out there. We can use plasma expanders, and that'll help maintain or enhance fluid volume if a patient has lost a lot of blood during surgery. And then they also have these cold surgeries where they basically use cryo, very cold temperatures, to almost put the body into a state of hibernation, and that can also help to reduce the amount of blood loss and reduce the risk of hemorrhaging too much, losing too much blood. Looking at our pre-op assessment and our checklist, as nurses we have a nice long checklist where we have to check all these boxes prior to the surgery to ensure that we don't miss anything. So it's important that we know the patient's allergies, because during surgery sometimes they use iodine to clean the body, and if a patient's allergic to iodine, that can really be a big problem. Important that we assess for latex allergies. A lot of the materials that are used in surgery may contain latex, so very important that we assess for that. It's important that we know all the medications that a patient is taking prior to the surgery, because if they're on a blood thinner, like Coumadin, like Plavix, other anticoagulants, what that does is it thins the blood, and people who have too thin of blood, they are at risk of hemorrhaging, of bleeding out, because their ability to make clots is reduced. So very important that before surgery we know if they're taking NSAIDs, aspirin, certain herbal supplements, vitamin E, because they may have to stop taking those medications for a few days, maybe a week or two prior to the surgery, so that we don't cause them to lose too much blood because their blood is too thin. So very important we know all the medications that a patient is taking. Some of the medications are recommended to take, certain heart medications. The doctor will give us orders on what medications we should be giving prior to the surgery. Sometimes they allow these meds to be given with a tiny sip of water. So make sure that you look at the doctor's orders to ensure that we're doing everything that we should be doing before the surgery. Sometimes we're gonna have to, most of the time, we're gonna have to restrict what a patient is gonna put in their mouth. So no food or fluids, usually before midnight. Sometimes it might be a bit more, a bit less, depending on the type of surgery. But if there is an NPO order, which means nothing by mouth, it's very important as the nurse that we enforce that, and for some patients that's hard to do because you go more than an hour or two without drinking, and you can get pretty thirsty. So we really got to abide by what the doctor's orders said as far as is the patient able to take anything by mouth prior to the surgery. Usually the night before the surgery, as well as the morning of, we're going to be doing these special CHG baths, and we do the whole body. Sometimes we do it once, twice, maybe thrice. It's important that we decrease any microbes that may be hanging around on the body. We know that with the body, we have our normal flora. However, prior to the surgery, we don't want any of that hanging around, because it's possible that that bacteria can go into the surgical site and become an opportunistic infection, which can really harm the patient. So very important that we do these special baths. Sometimes they tell them to take a shower, and then we give them a special CHG bath. We have different kinds of soaps that we can use, so depending on whatever your facility uses, we ensure that we do that in a timely manner. If we have to remove any hair off of a patient, we want to avoid using straight edge razors. You would more just use hair clippers, because with straight edge razor, you have the potential to cut the skin, and anytime that you compromise the skin integrity, that puts the patient at risk. So lots of hair in the body, we're just going to use a clippers to kind of trim it. We want patients to remove their nail polish if they have any, because we need to put a pulse ox on their finger to monitor their oxygen tissue saturation. So no nail polish, makeup is removed, and then it's important that if someone does have permanent makeup, like a tattoo, some people get their eyebrows tattooed, we note that in the pre-op checklist so that the surgeons aren't trying to scrub that permanent tattoo away. As far as consent is concerned, it's important that the physician or the surgeon talks with the patient prior to the surgery to get any answers, any questions answered that the patient may have. Also during consent, the surgeon kind of explains, risks, benefits of the surgery. There's always the potential with any surgery that something could go wrong, or you have the risk of infection definitely with any surgery. So it's important that the physician goes over that with the patient to relieve any fears or questions that they may have. As the nurse, the role of the nurse is you can witness the signature of the consent. Important to note that patients have the right to withdraw consent at any time, even after they've signed it. So that is a patient right, the right to refuse or withdraw consent. Important that we let them know that they have that ability as well. Looking at the different surgical risk factors and complications, some of the diseases that patients may present with that puts them more at risk for surgical complications. We know that with diabetes, the stress of the surgery may cause these swings in their blood sugar, and it can also be difficult to control blood sugars, especially if they've been NPO, if they have infection, something like that. Also with diabetics, wound healing tends to go down. Their ability to heal wounds definitely can be compromised. There's also this greater chance of the wound separating after the surgery. We call that dehiscence. In a lot of cases, some of our diabetics may be a bit overweight, so that really puts strain on the surgical site and it can open up and dehiss. The incidence of infections much higher in diabetics, and then liver and kidney disease make it more difficult to metabolize and eliminate the anesthesia and waste products that are associated with surgery. Looking at our patients who are advancing in age, healing is slower in the older adult. The risk of disuse syndrome, hypostatic pneumonia, inflammation and consolidation of the lungs, and then also blood clot thrombus formation is much higher in older adults, especially if they're inactive. The very young person, we know the very young person can be at risk during surgery because their body is immature. It's possible that their immune system is not quite mature enough to be able to handle any onslaughts by microbes, bacteria, virus. Also with our younger folks, they may not be able to regulate their body temperature as well. So that's an important consideration. And then they're also more at risk for dehydration because the younger you are, the more body weight that you have in water. With peripheral vascular disease, that is where there's poor circulation of the extremities, that can predispose patients to possible clot formation, thrombus formation, and then also pressure sores are more likely to occur on the lower legs and feet. So we definitely want to consider the use of anti-embolism stockings or devices that are generally prescribed for use during and after the surgery. Patients who have respiratory diseases are a very at-risk group of people because many times during surgery we inhale anesthetics, and that can irritate the respiratory mucosa, creating more secretions. With immobility, there's a greater probability of accumulated secretions and inflammations in the lungs and bronchial tree. Also with respiratory diseases, there's impaired oxygen, carbon dioxide exchange, and that can lead to acid-base imbalances. Finally, our big at-risk group of surgical patients are the smokers. Smokers causes increased lung secretions from anesthesia, and that predisposes the patient to atelectasis. Atelectasis is basically your collapsed alveoli. The alveoli in your lungs, they're the small grape-like structures. You got a whole bunch of them. And the alveoli is where the exchange of gas occurs, where carbon dioxide leaves, oxygen comes in. And so if those alveoli are collapsed, we call that atelectasis. So our smokers are much more at risk for developing atelectasis. Also, smokers more prone to thrombus formation. Looking at the information that we should be giving to our surgical patients, we definitely want to be teaching them about the pre-op procedures, if there is some kind of skin preparation involved, care of their belongings. Many times during surgery, they can't take jewelry into the surgery. We also want to tell them about the restriction of food and liquids, and then also any administrations of sedatives or pre-op medications. Many times right before the surgery, we may be giving a antibiotic prophylactically so that just kind of reduce the risk of a patient developing an infection. Some technical information we want to give them: the anticipated surgical procedure, how long it's going to last, how long recovery is going to take, the location of the incision, if there's going to be any tubes, dressings, drains, catheters, or any other equipment that's going to be expected. Are they going to need a cane, a walker, some kind of prosthesis, a boot, a cast? We want to go over all of that before the surgery. As far as the day of surgery, we want to tell them about the time that they should be there. Many times patients have to show up a bit early for the procedure to go through a couple things. Their probable length of stay is important to go through. What the pre-op meds are going to do to them, whether it's going to sedate them, where the family's going to wait, when and where the family can see them after the surgery. And then we also go over the ways that we're going to be controlling their pain during the surgery and also after the surgery. So once the surgery has taken place, after the surgery, we put them in the PACU, and that stands for the Post-Anesthesia Care Unit. And in there, they're basically going to experience, a decrease in light. They like to keep it a little bit dark. Sometimes there's noises, there's alarms going off. That can be distressing to the patient. So it's important that we tell them about that. They're going to be taking vital signs quite frequently in the PACU, and then also probably administering some kind of oxygen. Preoperatively, we also want to go over teaching correct breathing technique, when to cough, when to turn. Leg exercises are a high priority to decrease the chance of a clot forming. And then also with compression stockings, it's important that we go over with them, do you wear it before the surgery? How long do you wear it after the surgery? That's important to go to the care of the stockings. It's important that we put the stockings on before the surgery so that we can check the size and the fit. Because if compression stockings are too tight, it's going to be cutting off circulation rather than helping to promote circulation. Sometimes after surgery, it's important that we explain to patients if they're going to use an SCD, a sequential compression device. I always used to call those the leg squeezers with my patients. And basically you wrap this around their legs, it sends little puffs of air into it, and then alternately squeezes and releases pressure on a patient's legs. That also helps reduce the risk of a clot formation. Important that we teach a patient how to use an incentive spirometer. We use that to help get rid of the anesthesia, prevent atelectasis, and then also to help prevent pneumonia. So incentive spirometer, they put a little tube in their mouth, there's a little gauge. We tell them to breathe in, suck in like a straw. And then a little ball rises. They should be doing that, at least every hour for the first couple days. Very important that we do that. Prior to the surgery, it's important that all the surgical team members perform a timeout. And in that timeout, they're basically all confirming with each other, this is the procedure that we're going to be doing. We're going to be doing it on a specific body part. So sometime in the past, I'm sure this came about because a doctor or a surgeon performed surgery on the wrong side or on the wrong site. So we do this timeout as a safety to the patient, to kind of verify that it's the right surgery, the right place, the right site. Intraoperatively, some important considerations. They keep the OR, the operating room, pretty cold. They do that to discourage microbial growth. The goals of anesthesia administration during the surgery are to prevent pain, achieve adequate muscle relaxation, calm fears and anxiety, and then induce forgetfulness of an unpleasant experience. So just think about if you went into a surgery and you weren't asleep, your body's gonna tighten up. So this anesthesia really helps relax that body so that they can get in there and do whatever kind of surgery they need to do. Big safety alert, if a sedative is given preoperatively, it's important that we put the side rails up on the bed per facility protocol, or lower the bed. We also want to place the call light within reach, remind the patient not to get up without assistance, because once we give that sedative, it's there's a potential that the patient could become confused, disoriented, their muscles aren't going to be working like they should, so there's a potential for a fall or injury if we don't do those important things. General anesthesia usually puts the whole body to sleep. It's important that we watch their breathing closely with that. There's going to be an anesthesiologist watching over them. Usually they intubate the patient so that they can achieve proper oxygenation. With regional or local anesthesia, that only puts a specific body part to sleep. So with that, there's less risk, a lot less risk of respiratory depression, respiratory problems, potential that the part of that body, with general anesthesia, putting the whole body to sleep, there's a potential that, maybe the kidney's gonna be slow to wake up, the intestines might be slow to wake up. With local or regional anesthesia, we're only putting that specific site that we're operating on to sleep, so there's a lot less risk involved with that. Some of our potential intraoperative complications of surgery include hemorrhage, infection, fluid volume excess or deficit, hypothermia, malignant hyperthermia, where the body all of a sudden just heats up a lot, blood pressure, pulse go up, or there could be the potential for an injury related to positioning. So when a patient is in surgery, sometimes they're in a specific position for an extended period of time. And anytime that you're in a position and you're not moving, you have the potential to injure that area. So it's important during surgery, we monitor, especially surgeries that are a bit longer, monitor for any skin changes or possible skin breakdown during the surgery from being in one position for too long. Postoperatively, the PACU provides care for all basic needs. The patient is positioned to prevent aspiration and promote lung expansion. We try to warm the patient back up. Remember that operating room is pretty cold, so we're going to give them warm blankets, reassure them the surgery is over. Hopefully everything went okay. We're going to be taking vital signs every 5 to 15 minutes until the patient's stable. Emergency equipment is on hand in case the patient goes into respiratory depression or something like that. The patient's going to remain in the PACU until vitals are stable and they are awake and able to respond to stimuli. Postoperatively, the nurse must ensure safety and implement specific interventions based on the surgery. Intake and output are closely monitored to ensure that the kidneys are functioning adequately. The nurse can be listening for the return of bowel sounds prior to giving anything by mouth. And usually, once bowel sounds do return, we may start with sips of water, clear liquids, bland diet, and then upgrade the patient, as ordered. Sleep, nutrition, wound care, and other interventions are important for the healing of the patient postoperatively. Monitoring of the surgical site is important to establish should wound hemorrhage occur or signs of infection show up. And then finally, discharge instructions regarding wound care, new medications, therapy schedules, and precautions will involve the patient as well as any family members or caretakers that are going to be present. Okay, I hope this video was helpful for you. This was the Peri-op, so that includes pre-op, intra-op, post-operative. If you found this video helpful, make sure that you subscribe, give me that thumbs up, and then also comments are much appreciated. We'll see you next video.